WXXI's live forum is made possible with support from Excelis Blue Cross Blue Shield, with a mission to help people live healthier and more secure lives through access to health care.
Good evening, I'm Evan Dawson. Thanks for joining us for WXXI's live forum, COVID-19 Vaccines on the Horizon, a partnership with the University of Rochester Medical Center. The first vaccines for COVID-19 arrived in New York State this past weekend. Some healthcare workers have already received their first dose. The vaccines have been developed in record time, and some of that research was done here in Rochester. Tonight's panel of experts has been at the forefront of that response. They are here to explain how it happened, why the vaccines are safe, and what comes next. Our guests are joining us in studio and remotely. We want to emphasize they are physically distanced from me, our crew, and one another. Our team is wearing masks and taking every precaution to ensure everyone is safe. Let's get to it. I'd like to welcome our guests, and as we do that, we're asking each of them to describe themselves for members of the audience who are blind or visually impaired. I'll start. I'm a white man in my early 40s. I'm wearing glasses and a suit and tie. Joining us remotely tonight, Dr. David Topham, professor in the Department of Microbiology and Immunology at the Center for Vaccine Biology and Immunology, director of the New York Influenza Center of Excellence, and director of the Translational Immunology and Infectious Disease Institute at the University of Rochester Medical Center. Dr. Topham, please describe yourself.
Good evening, Evan. I'm a white male in my late 50s, and I'm wearing a light blue sweater and a blue Oxford shirt.
Welcome. Thank you for being here. Dr. Edward Walsh, professor of infectious diseases at the University of Rochester Medical Center and head of the infectious disease unit at Rochester General Hospital, who is leading the local trial of the Pfizer vaccine. Dr. Walsh, welcome. Please describe yourself.
Thank you. I'm a white male in my early 70s. I'm wearing a suit and tie.
Joining us in studio, Dr. Angela Branch, assistant professor in the Department of Medicine and Infectious Diseases and co-director of the Vaccine and Treatment Evaluation Unit at the University of Rochester Medical Center, who is involved in the local AstraZeneca vaccine trial. Dr. Branch, welcome. Please describe yourself.
Good evening. I'm a black woman in my 40s and wearing glasses.
And Dr. Nancy Bennett, director of the Center for Community Health and Prevention and co-director of the Clinical and Translational Science Institute at the University of Rochester Medical Center, who this week was tapped to co-lead Monroe County's Vaccine Distribution Task Force. Dr. Bennett, welcome. Please describe yourself.
Thank you, Evan, and it's a pleasure to be here. I'm a white female in my early 60s, and I'm wearing a red jacket.
And just a reminder that you can submit your questions for the panelists this hour by emailing forum@wxxi.org or by tagging WXXI News on Facebook and Twitter. Dr. Bennett, I'd like to start with you. We are seeing the first round of vaccine distribution now. Never seen so many happy doctors and nurses. 170,000 Pfizer doses in the state. Next week, we'll see 346,000 doses in the state from Moderna. I know you've worked on vaccine rollouts before. This is complicated. Does the process you are seeing make sense?
Yes, I think this process does make sense. It's happening very quickly. In the same way that the vaccine was developed very quickly, our process to vaccinate our community is happening very, very quickly. But we're putting a structure together. We're working very closely with Monroe County, where they have an incredible team in place already. In addition, the University of Rochester was tapped to be the hub for the Finger Lakes region, so we'll be working with people from across our region. We're setting up teams that will focus on operations, logistics, communications, every possible angle that we need to be sure that we can roll out these vaccines in an equitable and efficient manner. One important thing to know is that there are tiers that have been established nationally and with local variation in different states, and we will be following that tier structure. And what we're seeing right now is the first tier, which is healthcare workers who have direct contact with patients and long-term care workers and their patients. There are following tiers that are people who are at slightly less risk than that first tier, but we will be getting to those tiers as the months roll along.
And I'll ask you right now, because I know listeners and viewers are going to be wondering, should I be calling my doctor's office to, number one, either find out when I'm going to get it or to advocate for myself to move up the list, or maybe my parents to move up the list?
please, please don't call your doctor's office. They are swamped as it is. As you know, we have a lot of COVID in the community, and it's the winter, and we have lots of viruses in the community. So it's critical that you not call your doctor's office. And it also is important to understand that this whole system has been developed with equity in mind. The plan is that people are in a line based on the extent of their exposure. So we're really trying to get to the people who are at highest risk first. But everyone will get the vaccine. It's just a question of time, and we all need to wait our turn. I'm probably not going to get the vaccine very early because I don't see patients anymore. And I think all of us just have to be patient and wait until it's our turn.
And just briefly, Dr. Bennett, we just saw a video of the first hospital workers in Rochester being vaccinated. We know how complex this will get when we start to get to the general population. Could we see pharmacies like CVS come into play, especially if there's still a lot of COVID in the community and hospitals and doctors are busy dealing with COVID?
Yes, this is all hands on deck. We will be using every possible way of delivering vaccines. So it may be in your doctor's office, it may be in a pharmacy, it may be at a public clinic. Really anywhere that we can deliver vaccines safely will be a possibility for this vaccine. It's a little hard to predict right now what percentage will be and what setting, but we'll learn that as we roll out the system.
And I want to turn to Dr. David Topham. We have already seen 2 separate vaccines authorized, and within the next month or 2, we could see AstraZeneca, we could see Johnson & Johnson and others. A lot of the focus early on in the media coverage has been about how effective. When we hear these numbers, 95% effective here, 94% there, 70% here. How fixed are those percentages, those numbers, and should the general public be saying, hey, I want one vaccine over another?
You know, those numbers are too close together to really be significantly different. And I think as the vaccine rolls out, you know, everybody responds to one vaccine or another in a different way. And that's affected by their previous immune history, their health, et cetera. So I think what you'll see is you'll see very high efficacy. All of the vaccines are far more efficacious than, say, the standard seasonal flu vaccine, and are well above the levels that FDA would consider when approving these vaccines.
So if it's 95% now, it may not be 95%, but it's still going to be a good, strong number, it sounds like, for all of these vaccines.
Yeah, hey, it could be 96% or 97%. We don't know. I'm not saying it's definitely going to go down. I just it's hard to predict. The more people you put things into, the numbers are going to change a little bit.
Sure. And the vaccines created by Pfizer and Moderna, we're talking about brand new vaccine technology, mRNA platform. Give the audience a sense of what that means and how it might differ from vaccines we've seen in the past.
So, yeah, these are new platforms. The mRNA stands for messenger RNA. Messenger is a term for how information is carried from the genome to the machinery in a cell that and to instruct it how to make a protein. And so these mRNA vaccines, they're in nanolipoparticles, which directly enter the cell. They don't enter the nucleus where the DNA is, so they have no chance of mixing with the DNA. And there are enzymes that will read these messages and turn them into SARS-CoV-2 proteins, the spike protein in particular, the one that's on the surface of the virus, and the protein that is the target of neutralizing antibodies. So they're very safe. They will not cause genetic alterations. And it's a real breakthrough that this is a new technology that hasn't been used before, but as we've seen from the numbers, it's incredibly effective.
Well, it sounds like now that we know it can be effective, sounds like we will see it in the future. I want to turn to Dr. Branch. The best case scenario for a vaccine, Dr. Branch, is that, a person gets a vaccine and gets prevented from having an illness at all. But my understanding is that even the people in the trials who have received the vaccine, not the placebo, and then gotten COVID, it's not a large number, but for those folks, they have not had severe cases of COVID. Is that one of the goals of this vaccine?
Yeah, I mean, as Dr. Topham mentioned, the actual efficacy numbers may change. They may differ from vaccine to vaccine. They may even change as we vaccinate more people. So I think sometimes we get fixated on what the actual number is in a specific trial, but what we need to understand is the real goal of vaccination, the real goal of developing these vaccines is to prevent people from having illnesses that require medical attention, that require hospitalization. So if you have a vaccine that for 100% of the people you give it to, no one develops anything more than a mild cold, you have an excellent vaccine, a really excellent product, and you've achieved what we're trying to achieve. And it's possible that you may get vaccinated and a small percentage of you may still get infected, but it may be an asymptomatic infection, it may be a mild infection, and that's still considered a really, really great outcome.
Yeah, and Dr. Branch, one of the big unknowns has been immunity. Are we now getting a better sense for what kind of lasting immunity people receiving these vaccines will have?
Yeah, so when we conducted trials and we look to see if these vaccines produce an immune response that we think is protective, what we're comparing it to is the level of immunity achieved by someone who would become naturally infected. And so going into these trials, we already have a pretty good sense that the magnitude of the immune response will be protective. What we don't know is how durable it is and how the different parts of the immune system will be stimulated by the vaccine. But as we've been conducting these trials, we're starting to learn a lot more about that. We're seeing that the immunity potentially can be durable, can last 4, 6 months, a year, maybe even longer. And that, like with other viruses, that immunity may wane after a time, but we would still expect it to be there to some degree and still offer some partial protection.
All right, let me turn to Dr. Ed Walsh. Dr. Edward Walsh, the Pfizer and Moderna vaccines are available first. Both of those are 2-dose vaccines. Pfizer recommends 21 days in between the doses. Moderna recommends 28 days in between the doses. How exact, because you may have people in the population thinking, boy, I better know exactly where I'm going to be in 21 days or 28 days. Is there a little play in between those timelines there?
Yeah, there certainly is. I mean, the Pfizer study, which utilized a 21-day interval between vaccine, and the Moderna, which used a 28-day or roughly 4-week interval, both had windows around them of several days, and they certainly are going to be equally effective throughout those windows.
So let's talk a little bit about, Dr. Walsh, the people who get that first dose and wonder if that is enough. Do I really need to go back? Do I need a second dose here? What is your message, Dr. Walsh, for anyone who comes up with that question?
You absolutely need the second dose. The efficacy in the Pfizer trial between your first dose and before you got your second dose was significantly less than the 95% that was noted after 2 doses. And so the booster phenomenon that occurs with that second dose is very strong and will offer the maximal protection.
And Dr. Walsh, I admit my ignorance with vaccines. Generally speaking, I don't know how many 2-dose vaccines are out there, but I do want to know if you have concerns that some non-zero, but some large non-zero number of the population will get that first dose, but not a second. Does that worry you?
Well, it is concerning. I think to get maximum benefit from this, the second dose is important. I might point out that when humans are meeting a novel pathogen, and the best example of this would be with children, multiple doses of a vaccine are important.
All right, so let me turn to Dr. Bennett for the question of the night that nobody wanted to be asked, but this is the one that comes up probably more often than any others, Dr. Bennett. And I know it involves some speculation, but is there now a realistic timeline for every adult in the population to have been vaccinated if they want to? Is it April? Is it June? Are we getting a better sense of that?
That's the $6 million question. If only we had an answer to that. I think that there are lots of realistic timelines out there, but which one will be correct is very difficult to predict. It's not just whether or not we have all of the mechanisms in place to deliver vaccine. It's also whether or not we get the vaccine at the times we expect to get it. One of the problems that is very real is that we only have 2 approved vaccines so far, and that second one was not even fully approved today, but the advisory committee recommended its approval. With those 2 vaccines, we cannot vaccinate the entire population. So we are dependent on additional vaccines being approved between now and when we're trying to vaccinate everyone. So it's difficult. There are a lot of things beyond our control that will determine what the timeline is. I think many experts think that we will be able to get to most of the population by next summer. I'm not betting on anything.
Fair enough. And when it comes to that communication, that becomes one of the most difficult jobs that you and your co-chair and others in the county and in the region will have. I know there's not a direct answer today, but are you confident that when it comes time to communicate with the public, instead of having them all call you and the doctors, you want to call them? Is there going to be a good way to keep that flow of information going?
I certainly hope so. That's what we're planning on. I think throughout the distribution of this vaccine, the most critical element will be communication. And it's going to be communication around a number of issues. Some of it's going to be logistical. You know, when are you going to get your vaccine? Where are you going to get your vaccine? But some of it is also going to be reassurance and helping people to really understand how the vaccine works, why it's safe, why it's effective, and really just filling in all the gaps in people's information. I think that the fact that this vaccine is a new technology makes people very nervous, and we have to continually talk about why it's such a great technology. You know, there are lots and lots of other questions about the vaccine that we have to answer over and over and over again. So I think transparency and continual communication is going to be the name of the game.
Yeah, and just briefly, Dr. Bennett, if someone, well, we're all going to eventually be on the list of having a chance to get it if we are adults, or most people will. Will you likely have 2 or 3 days lead time? Is it a week? Is it sort of a general range? Do we know that?
Oh, yeah, no, people will have plenty of time. It isn't like you're going to get a telephone call in the middle of the night that says you have to be there at 8 o'clock tomorrow morning. It won't be anything like that. We'll be doing tiers. People will be getting vaccines at multiple locations. There will be lots of notice. It's not a show up or miss out.
Well, let's take a look now at New York's vaccine timeline and some of the phases here. Phase 1, which is where we are now, healthcare workers in patient care settings, long-term care facility workers, and more at-risk long-term care patients. Phase 2 will include first responders, teachers and school staff, child care providers, public health workers, other essential frontline workers that interact with the public. Also, Phase 2 will include other long-term care facility patients and those living in other congregate settings, and individuals in the general population deemed particularly high risk due to comorbidities and health conditions. Phase 3 will be individuals over 65 or individuals under 65 with high-risk comorbidities, and Phase 4 will include all other essential workers. Phase 5 is the rest of us, healthy adults, and then eventually children. Dr. Topham, we've had questions from people in different phases of this rollout about side effects. Every vaccine carries some potential for side effects. What should we know about side effects and COVID vaccines?
So side effects from vaccination are normal. These vaccines are very potent. The reason why we got those high efficacy numbers is because of that. They induce a strong immune response, and a strong immune response has symptoms. So their symptoms are typically mild, and they don't last for more than a day or so. But they include things like injection site pain, muscle aches, fatigue, chills, and things like that. And they can actually be severe enough on the following day to make it that you're going to have to miss a day of work. But that, we should expect that. But none of them are permanent. The reports we're getting is they last at most 24 hours. I haven't heard anybody who said they had it for more than a day. And again, unfortunately, side effects like that are not something we're used to seeing with, getting vaccinated as an adult. Maybe the exception is the Shingrix vaccine. I hear that's got some pretty significant side effects. But again, it's a good vaccine. It's potent. It's effective. And so, when a vaccine is effective, you're going to feel it.
So let's take a look at some of the results from the trials. This is from Pfizer's first dose, and this is some of the results for side effects. And I'll read them for you. You can see them on your screen. 47% of those who had the vaccine had fatigue, 42% had headache, 14% chills, 21% muscle pain, 4% fever. Those are adults under the age of 55. The older you get, 55 and older, those symptoms were less commonplace. So 47% fatigue under the age of 55, 34% over 55, 42% headache down to 25%, 14% chills down to 6%. So if you look down this line, Dr. Topham, what's going on there? I mean, I actually find that quite comforting for people who are worried about, I think about my mother, and I think, well, good, I'd rather have side effects than her. That's sort of a good thing. But do we know why that's going on?
Yeah, there's a couple of reasons for that. One, as we age, our immune systems aren't quite as strong as they are when we're young. And so the response to the vaccine may be a bit less strong. The other thing is, and I've talked to my clinician friends about this, and it's just a theory. When people get old, they have aches and pains all the time. And so having a little bit more aches and pains, you can't really tell where they're coming from. It just goes with the territory. So they tend to report less symptoms than younger people.
Are you calling me a complainer?
No, we're still in that young age bracket. Trust me, you get a bit older and, you have pains. You don't know where they came from and what the reason is.
Well, in a very serious note here to Dr. Topham's point, though, if you end up with side effects from this vaccine, that is normal. It's a sign that it's working. And as much as what might feel, quote unquote, Dr. Topham, severe to us, whether it's fatigue or, boy, it was hard to get out of bed, it was I was kind of dragging, feeling a little rough, I didn't want to go to work for the day, that is technically mild. I mean, that is not something that we classify as anything other than normal with this vaccine, right?
No, and I can tell you that even people who have had infection with mild symptoms have much more side effects long term than anybody who's getting vaccinated. So you really, really should prefer getting vaccinated and not getting infected. If people think that they're better off just getting the natural infection, they're wrong. The vaccines are much safer, and actually they may end up being more potent and effective at producing a long-term immune response.
Now, we've talked to a couple doctors today, and we'll talk to Dr. Mendoza later this hour, who was vaccinated yesterday. I'm not sure he's had anything other than a mildly sore arm, so it's life in the vaccines here. I want to share some thoughts now from Wade Norwood, the CEO of Common Ground Health. His organization has been working with communities of color who have developed mistrust over many decades of abuse and discrimination in medical research. He spoke to us via Zoom about the urgency of restoring trust.
Dr. Fauci made a statement early in the experience of the pandemic that what COVID-19 is doing is it's not creating new problems. It's bringing a spotlight on and exacerbating problems that we've known with the healthcare system for decades. And one of those major areas of concern is the level of trust that exists between the Black community in particular and the healthcare system. Without a doubt, the route to making sure that we're able to build trust is through information and relationships. And we are well served in this community by having invested in and supported grassroots advocacy, grassroots voices, and leadership that are really trusted in the community and that are very concerned about improving health. And so the fact that the clergy, the fact that community groups like the Black Physicians Network and the Black Nurses Association, the fact that neighborhood groups and community organizations like Action for a Better Community or our own African American and Latino health coalitions, these groups have been already at work in the community. At Common Ground, our staff has been conducting a Facebook Live broadcast series, Mythbusters, where one of the nurses and a doctor on our staff are having regular conversations with the community. I think the key is that we're beginning the work now, and that the work has to be done by the community. It has to be done not only for the community, but it has to genuinely come of the community. And we have a lot of work to do because there is a long history of medical science really poorly serving African Americans. And its roots are in the history of African enslavement in this nation. They run famously through Tuskegee, but they extend to today, where beyond the Black community, the federal government just recently was illegally sterilizing Latinas in custody of Border Patrol. It is not irrational for there to be fear and mistrust, but the only way to address fear and mistrust is through information and through engagement.
We so appreciate the thoughts from Wade Norwood. And before we turn to Dr. Branch for her thoughts on that, we want to hear from an environmental services staff member at Strong Hospital who received the vaccine on Tuesday. This is Robert Fitzpatrick.
Me being African American, so a lot of my older friends that I have, you know, I'm not getting it, and they all want to bring up the experiment they did back in 1930s and all that, and you know, and I just tell them, do your research. You know, it's not the 1930s. They're not out to get us, okay? You know, it's here to save us.
Dr. Branch, we heard from Wade Norwood, we heard from Robert Fitzpatrick addressing what is certainly out there, mistrust based on decades in the past here. What is your message, especially for communities of color that harbor that mistrust?
So there's been an awful lot of emphasis placed on this in the news, and you know, I've been speaking to lots of groups and media about this surrounding this issue. And I think first I'd like to point out why it's important. Health disparities erasing health disparities is a long-term goal that I think as physicians and people who work in healthcare, we all need to own and continue to work towards solving. But when you're talking about COVID in specific, you really want to know that you will be able to vaccinate the people who are at highest risk of severe disease and of dying from COVID. And so there are certain groups that will be maybe more easily successful at doing that with older adults, adults living with underlying comorbid conditions. But when you're talking about minority communities who are being disproportionately affected by COVID-19 in terms of rates of infections, rates of hospitalizations, and rates of deaths, that's going to be a much heavier lift. And so we have to really think outside the box and work extra hard to make sure that we're reaching those communities with the right message, and the right message bearer is taking it there. And it starts with education, as Mr. Norwood said. I think that one of the major issues that contributes to health disparities, and one of the things that's going to be the biggest barrier to getting communities of color vaccinated, is making sure that we are able to disseminate information while there. And we're going to have to really work with our community partners, leaders and activists in the community who already have established trust with these groups that we're talking about, and partnering with them and giving them educational tools and helping them deliver the message is really what's going to be the most effective.
And Dr. Branch, Dr. Anthony Fauci has stressed that one of the vaccines was essentially developed with the lead of an African-American woman. The first vaccine given in New York State was administered by a black woman, and the shot went into the arm of an African-American nurse. Do these stories make an impact?
I think they definitely do. One of the reasons why we've worked so hard to make sure that our trials are diverse and that they have a good representation of African Americans, Latinx, and Native Americans and Asians, because we want people to be able to go back and take the word to their communities. And so I think for people understanding that these vaccines have been developed by a diverse group of investigators, some of whom are African American, and that they've been trialed in a diverse group of participants, many of them who are Latinx or African American, I think will help to build the trust that's needed so that people will step out and say, you know, I'll get vaccinated and protect myself and my family and my community.
And Dr. Branch, Wade Norwood also told us there will be a significant challenge to get people to come back for that second dose of the vaccines. He pointed, for example, to blood lead level testing in children. He says first-year testing were widely accepted, but there's a drop-off in the second year, and he's worried about COVID vaccines and a drop-off with a second dose. What has to be done to ensure people get that second dose if they get the first?
I think that first point of contact with the person that walks into the clinic or the location that the vaccine is going to be delivered, that's the most important contact. That person right then and there has to build a rapport with the person they're vaccinating. They have to be able to talk through what this process is going to look like, explain a little bit to them that the first dose is not enough, that you really need the second dose for this to be effective. And then they need to make an appointment and a plan right then and there as to how they're going to bring them back or schedule them for their second dose. All of this has to happen with that first point of contact, and I think really engaging in that first meeting is really what's going to drive compliance and adherence to the vaccine schedule.
We spoke to the granddaughter of Henrietta Lacks. Henrietta Lacks was an African-American woman who died of cancer at the age of 31. Her cells helped doctors achieve massive medical breakthroughs, but those cells were taken and used without her permission and knowledge, and the medical community had a lack of transparency with the Lacks family. We asked Jerry Lacks, her granddaughter, about hesitation to get this vaccine. Listen to part of our conversation with her now from WXXI's Connections. Jerry, when COVID vaccines are broadly available to the population, do you plan to get vaccinated?
That's something I'm kind of on the fence with the vaccine, with being vaccinated. It seems like things are moving super fast with this vaccine. I don't know. Once they iron out the kinks, I'm quite sure that I would change my mind and will get the vaccine. But right now, I think things are too new, and I have to get more information.
Very common question, so let's give her and others more information about the speed. This is a very common question, Dr. Branch, a concern that either things move too fast or corners were cut or this vaccine shouldn't be available yet. Let's talk about that. What's the message for that?
You know, I really like people who are on the fence. I think that that's healthy. I think it shows really good sense because this has been a very fast process. And I think as investigators and scientists, we weren't sure we could do it this quickly because we never have before. But what's important to understand about how these vaccines were developed and how this program was sort of unfolded is that no safety standards were eliminated or were discarded or were overlooked in the development of these vaccines. So vaccines do take typically about 10 to 15 years to develop. And one of the reasons for that is that we spend maybe 5 to 8 years in the exploratory phase where we're working in the lab to pick the right compound, to put the pieces together so that you have a product that you might even consider potentially effective. All of that work was actually developed long before the COVID-19 pandemic. It started maybe as far back as 2003 and 2005 when we first saw a novel coronavirus emerge as a potential pathogen in human species. And in fact, that coronavirus epidemic that occurred in China in 2003 was more deadly than the current coronavirus. So all the way back to 17 years ago, we started work on figuring out how we could develop a coronavirus vaccine if there was ever a coronavirus pandemic. And so we were able to skip those 3 to 5 to 8 years that usually you have to spend in a lab developing that. Then we moved into the animal studies that you typically do with vaccines in order to determine both the safety as well as the right dose that might stimulate a good immune response. That was not skipped at all. That occurred just the way it was supposed to. And after being able to have a product that we thought potentially might be effective, we moved into our phase 1 trials, and we did everything we needed to do in order to confirm safety in a small group of healthy people before we moved into larger trials. We just did them not sequentially, where you might do one dose and then another dose and then a third dose in different age groups, but we actually did them in parallel so that we didn't have to spend another 2 or 3 years in that process. And the phase 2 and phase 3 trials have actually gone the way phase 2 and phase 3 trials always go. We've been considering safety. We've halted studies if we needed to, if there was any safety concerns. Independent safety monitoring boards have been reviewing everything, and the FDA itself actually required that we had a minimum of an average of 2 months of safety data after the second dose of vaccine before they would even consider emergency use authorization. So while I think that it was quick, we're in a pandemic, and the option to go slow just wasn't there. And I think that we've had so many years in the last 2 decades of developing new technology, of testing them, of developing vaccines, of working some of these things out, that we were really able to leverage what we already knew to make this an expedient process.
Remarkable. And let me turn to Dr. Walsh. Same kind of question. You've been involved in the development of a number of vaccines. How comfortable are you with the safety and speed of these?
Very comfortable. As Dr. Branch pointed out, none of the shortcuts that we took would affect safety or the available data that would be shown to produce an efficacious vaccine. And I think that the data is all there, and it was presented to the FDA and the advisory panel, and viewed as effective.
Dr. Bennett, well, as time has gone on, surveys indicate a growing number of Americans do plan to get vaccinated, but there are still significant percentages who say they won't or they're not sure. What is a realistic goal in terms of herd immunity, what we can achieve here? How concerned are you about eventually getting to that goal?
Well, ideally, we would like to get to 75% of the population to achieve herd immunity. And I think that's not unrealistic. I guess that's a double negative. But I think our community has shown in the past that we are able to demonstrate the ability to vaccinate our community members and to protect them from disease. We have generally higher vaccination numbers than most of the country in childhood vaccine, in vaccines for the elderly. We've been able to do a good job, and that's thanks to our providers in our community. I also think it's related to the fact that there's been a great deal of vaccine research done in this community. So having that research in the community has sort of heightened everyone's awareness about the value of vaccines. So I think it's not impossible for us to get to 70 to 75%. It's a high number, and it's a short period of time in which we want to achieve that. So it's not going to be easy at all. But I think we have all of the material to do it. We have an incredible healthcare system. We have a supportive community. We have, as Mr. Norwood said, we have a community that has come together many times before to address similar kinds of issues. Nothing is quite like a pandemic, but I believe that our community will be able to rise to this challenge.
If you're just joining us, I'm Evan Dawson here at the WXXI studios. Our panelists are experts in their various fields, and they are discussing what you need to know about COVID-19 vaccines. Now we'll hear from 2 local vaccine trial participants. They were involved in 2 different studies, and they spoke with us via Zoom to share their experiences. Here they are.
My name is Chris Gold, and I'm from Charlotte, and I was participating in the AstraZeneca vaccine trial.
Hi, my name is Corey Talinda, and I live in Charlotte, and I am a part of the Pfizer phase 3 vaccine trial.
In my experience, the trial has been pretty easygoing. I've been to RGH about 4 times for various blood draws, and I've received 2 injections. As far as side effects go, I've had minimal side effects. About 24 hours after each shot, I did have a little bit of malaise and some headache, but it went away within 12 hours. It's been a pretty good experience so far.
My experience has been great. I think the staff at RGH has been very thorough. in my consultations with them and through the whole process, going into the office and receiving the 2 injections as part of the trial has been easy. And they've been very forthcoming with all information and very supportive, no issues, and they're very professional.
My question is, when the vaccine's distributed and people start receiving the shots, how long will social distancing measures and masking have to remain in place for people to stop spreading the virus? And is there a critical mass of people who have to get vaccinated in order for those parameters to disappear?
It's a great question. I'll ask Dr. Bennett. What would you tell Chris?
I'd tell Chris that sadly we have to continue to social distance and wear masks for quite a long time until we get to a critical level of vaccination and until we see the rates of disease in our community drop down to a very low level. We will have to protect ourselves using those other methods that we've been using since last spring. It will take a while, it won't be immediate, and when someone gets a vaccine, they really will need to continue to protect themselves for the time being.
And now here's a question for Dr. Walsh, and it comes from Corey Talinda.
I was wondering, as a member of one of the 2 vaccine trials currently in Rochester, will I ever be notified if I receive the placebo or the vaccine? That way, if I receive the placebo, I could get the vaccine. Or on the other side of the equation, if I receive the vaccine, I won't receive it again, taking the vaccine away from someone else who could use it.
All right, Dr. Walsh, how would you answer Corey's question?
Well, the answer is yes, this will be happening. It's a bit of an unusual approach, but in the setting of a pandemic, the concept of continuing within placebo groups for long periods of time is considered a problem. And so this has been addressed at every level, from the FDA, NIH, down to the companies that are manufacturing these vaccines, as well as the investigators.
So is there a timeline? Maybe the next couple of months you'll let people know if they had placebo?
Well, for example, currently with the Pfizer vaccine, and I would presume this will occur with the Moderna as well, the healthcare workers who would currently be eligible for vaccination, whether they were in a trial or not, are being unblinded, and they will receive a vaccine through the study. This, of course, would allow more vaccine available to other healthcare workers who were not in vaccine studies.
I'm going to turn to Dr. Branch. We spoke with you all the way back in April about treatments like remdesivir. So outside of a vaccine, we got to get better at treating COVID. Now we know there's maybe other treatments that are better than others. How much better are we at treating COVID? How much better can we get with it?
I think we're a lot better, and I think this has a lot to do with the intensivists that work in ICUs, with the nursing care, with the hospitalists, the medical hospitalists who work in the floors, with the nursing care on the floors. I think on every level, we've learned so much about COVID over the last 9-10 months that we know how to prevent people from deteriorating. We know how to prevent them from dying. We know how to utilize ventilators in a way that's actually beneficial and not harmful to patients. We know what supportive care they need. So I think we're going to see that the percentage of people who die that are hospitalized is lower with this second surge than with the first surge. Having said that, we are still seeing too many deaths, and then the absolute numbers are higher, and that's because there are more infections now than there were in the first surge. So as good as we've gotten at managing COVID illnesses, we have to do better. And I think that will require better therapies, and we're continuing to develop new treatments, continue to do trials in the hospitals of these treatments, and there's always the hope that we're going to find better ones than the ones we have now.
In the next 5 minutes or so, we're going to get through as many audience questions as we can, and anything we don't get through, we're going to try to squeeze in an after program on Facebook Live, WXXI's Facebook Live page. Let's go through them now. First, this comes from Nita, and I'll direct it to Dr. Topham. What about vaccinations in women who plan to become pregnant or are already pregnant? Any recommendations or data on that? Dr. Topham.
Well, my first recommendation would be to speak with your doctor. and see what their advice is about getting vaccinated. What we do know is that women who have been pregnant and infected and given birth, or women who got infected shortly after birth, they do not shed virus in the breast milk, and they actually are able to convey immunity through breast milk by transferring antibodies to the infants. And so this could be of tremendous benefit to protect those infants from getting infection. So the bottom line is that if a mother has had COVID-19, it's okay to breastfeed. Now, with the vaccination, I don't think the vaccine has been tested specifically in pregnant women. So there's a few unknowns there. But like I said, I think I would consult with my obstetrician and take their advice.
All right, I'll direct the next question to Dr. Walsh. Sarah asks, do we know if children participated in the vaccine trials? Will there be guidance regarding how children should get the vaccines and if it's different from how adults receive them? Dr. Walsh.
The Pfizer study studied children down to age 16, so 16 and 17-year-olds, and the emergency use authorization included that group. We do not have much data at this point going beyond age 16, but those studies are in progress. The Moderna study that was submitted for their EUA evaluation by the FDA is only for adults 18 and above.
When are we going to get data? Do we have a sense for when we'll have more data on kids and when kids might be vaccinated, Dr. Walsh?
Well, it's a slow process because you move down slowly. You may move down to say, 12-year-olds fairly quickly, but once you go beyond that age group, you tend to go a little bit slower. And so the studies will be dependent on, of course, results with the older children as you move down to younger children. And this would be a standard procedure for most pediatric vaccines.
Kids get patient, it sounds like. They're down the list here. Our next question is for Dr. Branch. Brian asks, how does the immunity from a vaccine measure up in strength and duration compared to fighting off COVID naturally? Dr. Branch.
So as I mentioned earlier, when we choose a vaccine to move forward into phase 1, 2, and 3 trials, one of the things we're looking at is, does it confer the same kind of immunity in terms of magnitude as you would get if you're naturally infected. So in all of the phase 1 trials for all of these vaccines, that was the gold standard. We collected blood samples from people after they had been naturally infected and recovered, and we looked to see what kind of immune response do they have? What are their antibody levels? Do they have other supporting immune responses in terms of other cells like killer T cells and so forth? And then you compare that against your vaccinees. And if you're able to elicit an antibody response that's similar to what you would have if you'd been naturally infected, then you know you have a vaccine that's potentially protective. So the hope is, and the expectation is, that these vaccines will confer immunity that's similar to what you would have if you had gotten naturally infected, but without the risk of infection, and that the durability of that immunity will be at least as good, if not better.
Could be even better. And finally, Dr. Bennett, Mario asks, is the vaccine free for all Americans or only covered through insurance?
So the vaccine itself has been bought by the federal government, and therefore there's no cost for the vaccine. When it's administered in a doctor's office, for example, the doctor could bill your insurance for receipt of the vaccine, but they will not bill you, and there will be no copay. There can be no financial barriers to receiving this vaccine in the U.S.
All right. We have plenty more audience questions, which we will get to on Facebook Live. I want to turn now to Dr. Michael Mendoza, who is the Monroe County Commissioner of Public Health, who is with us now. Dr. Mendoza, great to see you. For our viewers and listeners who are blind or visually impaired, please describe yourself.
Good evening, Evan. I'm an Asian male in my mid-40s, and I'm wearing a light blue sweater.
You were vaccinated yesterday?
Indeed.
How are you feeling?
Well, I feel fine. You know, it's ironic that one of the symptoms listed on the side effects was fatigue. You know, anybody who got the vaccine this week already had fatigue, but the rest of us, we're doing just fine.
I'm glad to hear that. Well, tell us a little bit about your view of the county's role in vaccine distribution. We've been talking about that tonight. This is a big challenge. What is the county's role here?
Well, I think our role is to take a leadership role, to understand where the community is, to appreciate that, and to Dr. Branch's point, I think that a lot of people are on the fence, and I think that's a welcome opportunity for us because it gives us a sense of direction as to how we need to educate the public about all of these questions. And tonight's event underscored a lot of the things that many people are uncertain about. And so I think our role is to take a leadership role in the education, to make sure that we establish equity from the standpoint of administration, and to communicate. One of the challenges with an undertaking of this magnitude is that there's so much information, some better than others. And our job is to vet that information, to ensure that the public is getting the most accurate information, and to be honest about the things that we are still learning about. Because the reality is that there is still a lot about this vaccine. There are still a lot of questions about how it's going to be administered and in the magnitude that we're anticipating, in the next 6 months. Our job is to be honest about what we know and to be honest about what we don't yet know.
If you could, I'd like you to address the very real concern that some viewers will have, because in one sense, you're talking about convincing people who are on the fence to say, yes, I'll get the vaccine. In another sense, you will have people say, hey, you need to move me up, or you need to move my parents up. And they start lobbying and advocating. And you can understand why. There's a lot of emotion and fear. But that can complicate things. What is your message for the community members who might be thinking, hey, I'm going to call my doctor and say, my mom really needs it next, or you need to change the phase to suit certain people in my life? What would you say to that?
Well, there are always going to be people ahead of you in line, and that's just the reality when you have a fixed capacity of something that there's a high demand for. What I would say is this, that the operation will work more smoothly if we can establish clear parameters and appreciate that it's based on risk, and it's based on science, and it's based on data, and it's based on the reality that if things change, we'll readdress these tiers and we'll make modifications as necessary. But, at the end of the day, I don't think it really makes a big difference if you get vaccinated 1 month earlier or 1 month later, because we are all going to have to be wearing our masks through the entirety of this period. And, when we get the supposed green light at the very end, when we're no longer, needing to wear our masks and take all these precautions, then things will change. But between now and then, we're all going to have to take these precautions.
Doctor, I'm going to read a note that came from a viewer on this very subject who said, I've heard tonight, don't call your doctor's office, don't try to jump ahead in line, but how do I find out where I am or should be on the list? Who should I call, or where do I go to find out about that?
Well, that's a responsibility that I want to take on, because I think that's a very common question. And I want to communicate that to the public. I want to be able to help the public understand where they are in line, so to speak. And so as the weeks go on, that's communication that we're going to be developing.
Bottom line is, right now, we're in phase 1. And the vaccine distribution is going to people like Dr. Mendoza and healthcare workers. It will get more complex as we roll through the different phases. There will be opportunities to communicate. Some of that infrastructure and planning is being developed as we speak. And I want viewers to know WXXI will be communicating with health leaders. I can envision future forums just like this one to make sure you know. There will be plenty of discussions on connections and other platforms in WXXI News. And I know there's a lot there, but we'll all be involved in making sure there is communication. Even if it's not all in place right now, it's being developed. Now, Dr. Mendoza, another question that comes up, and we talked about this earlier, should we be prepared to say, hey, I guess I'm going to CVS or a pharmacy, not a doctor's office, in case, capacity is an issue or you need to work with different partners to make sure people get the vaccine?
I think we should be prepared for all of that, because the reality is that we can't administer this quantity of vaccines in this short a period of time solely within the walls of a hospital or even in primary care clinics. We will be looking at pharmacies. We will be looking at community sites. We will be looking at points of dispensing that we'll establish through the health department. But we don't have to do all of that right now. We're still in the learning phase. We have the blueprints ready, and we're developing them now, and we're fine-tuning them now. But to vaccinate 740,000 people, ideally, with 2 doses of a vaccine, will require that we get creative, and we're going to have to do this in ways that are unconventional by typical healthcare standards.
We have seen some very rough days with the number of COVID cases, hospitalizations, and deaths. Christmas is about a week away. What is your message for the community?
My message for the community is that, there is a good reason to have optimism. We have a vaccine on the ground. There are, people who are getting the vaccine now. But the reality is that there is still so much time between now and when this is over. And, we're protecting the people who are in healthcare who are going to take care of us and our loved ones if, unfortunately, we fall ill. But our goal is to prevent people from getting ill. Our hospitals are really very close to being beyond the point where they will be able to take care of us. And, we need to take that very seriously because the curve that we always worry about is the curve in the hospital that will make it impossible to take care of additional people, whether they come to the hospital for COVID-related reasons or not. So, we are perilously close to that limit. And so what I would tell people is continue to wear your mask, continue to follow the guidance, and continue to be very careful about who and how many people you invite for a gathering.
30 seconds, Doctor. I saw a TikTok from Boston of nurses dancing on the street when they got the vaccine. They were dancing to Lizzo. There was such optimism. Are you feeling that in the community of healthcare workers now? I
do. I saw patients this morning, and a number of my colleagues had gotten their vaccine yesterday as well. And this is what we've been working for. This is the day that we have all been waiting for 9 months now. I think it's natural for people to breathe a temporary sigh of relief. But at the end of the day, when you talk to people in the office today, that temporary feeling of relief is still somewhat tempered by the reality that we have a whole lot of work ahead of us. There are a lot of people who are sick that we've got to keep working with.
Thank you so much, Dr. Mendoza. And our thanks to all of our guests tonight, Dr. Nancy Bennett, Dr. Angela Branch, Dr. David Topham, Dr. Edward Walsh, and again, Dr. Michael Mendoza for joining us and doing important work during this pandemic. We'd like to thank you for joining us tonight for WXXI's Live Forum. You can find this broadcast and more information about COVID-19 vaccines at WXXInews.org. We want to know what you think about the program. You can call 258-0360 or email forum@WXXI.org. Our conversation continues now on the WXXI News Facebook Live broadcast. We'll have more of your questions answered. We'll see you there, and if not, stay safe and healthy, and good night.
WXXI's Live Forum is made possible with support from Excellus Blue Cross Blue Shield with a mission to help people live healthier and more secure lives through access to health care.
And we continue on Facebook Live for a few more minutes, try to answer as many of your questions as we can. I'm Evan Dawson. Thanks for staying with us. Thanks to all of our guests for being here. It's a little more rough on Facebook Live. I'm just going to go through as many questions as we can and direct them as sort of far and wide as we can. So thanks for being here, everyone. Dr. Walsh, I'll kick the next question to you. Comes from a viewer named Kathy who says, can you have a serious reaction if you get this vaccine and you've already had COVID, but you didn't know it? Dr. Walsh?
The answer is no. The study that was just completed with Pfizer, for instance, about 3% of the subjects in the phase 3 study were determined ultimately to have had COVID prior to their vaccination. And there was no evidence that there was any problem.
A similar question that we got this week, Dr. Walsh, is if I have COVID right now and don't know it and get vaccinated, any concern?
No, there should be no concern for that either.
Okay, simple enough. We appreciate that. Tim writes the following, and we're going to kick this over to Dr. David Topham. I find a number of people that believe because this is RNA-based, the vaccine will permanently alter their DNA. Please dispel that idea. Well, Dr. Topham, I think you did that in our main broadcast, but I'm going to ask you to do it again. Go ahead.
Yeah, I tried to. So messenger RNA is, made by every cell in the body, and it's actually sort of the end product of expressing your genes. And so it's very distal from the DNA that contains the primary information. These mRNA vaccines, the mRNA gets into the cell, into the, if you remember your high school biology, into the cytoplasm, the sort of, goo in the middle, but it does not go into the nucleus. And the proteins are made in the cytoplasm and then exported outside of the cell. So there's no chance that the mRNA can combine or interact chemically with your DNA and change it in any way.
I'm going to direct the next question to Dr. Bennett, and this is sort of a question on how the priorities and the lines work. Anne from Avon says, as a healthy, no predisposing conditions 72-year-old woman who wants to wait and see before getting this vaccine, if I therefore miss my turn when it comes in the vaccination schedule, will I be able to get the vaccine later when other tiers are being vaccinated? Dr. Bennett?
Absolutely. It's not as though there's a line, you have to get it at this time, and if you don't, then you can't get it. People will be able to get the vaccine going forward. The issue right now is trying to create a hierarchy, if you will, the tier system, so that we get to the most exposed or most likely to be exposed people first. But eventually this vaccine will become routine.
All right. This next question I'm going to direct to Dr. Branch. I believe, Dr. Branch, you've been working on, for example, AstraZeneca. Is that right?
Yes.
Okay. William says, when will the first non-messenger RNA vaccines be coming out? I don't trust the messenger RNA vaccines. Dr. Branch?
So the Johnson & Johnson or Janssen trial is finished enrolling, and they will probably have data sometime in January. We also believe that the AstraZeneca trial will complete enrollment this month, and we should have enough data, most likely mid to late January as well. So I'm hoping by the end of January, one or both of these vaccines will have enough data to apply to the FDA for emergency use authorization.
And we always respect people's rights to come to their own conclusions. But anything you want to add, Dr. Branch, for viewers like William who say, I don't trust messenger RNA?
Well, I got a messenger RNA vaccine today, yesterday, and the assurance of potential safety in the next couple of months that I feel was worth it. I think Dr. Topham and Dr. Walsh have really gone through some of the science of how these vaccines are made and why the messenger RNA itself is not something that can really harm you, and the protein that it allows your body to create in itself is also not harmful. So I think these vaccines are great, and I think it's going to probably be the future of vaccinations.
You got the vaccine yesterday?
I did, yeah.
Dr. Mendoza did too. How are you feeling, Dr. Branch?
Well, I had some arm soreness, and I feel tired, and I'm achy all over. But, it's hard to know. I've been sitting at a computer all day and working for the last 14 hours, so that could just be normal.
This gives me a chance to ask Dr. Mendoza just to elaborate a little bit before we jump back to questions here. I mean, Dr. Branch did a program for an hour with us yesterday, and on that hour on Connections, Dr. Mendoza turned around the viewpoints of one of our guests, a black man in the community who does great community organizing work, but said he just didn't trust vaccines. At the end of that hour, he said he's ready to go talk to people and maybe dispel their mistrust because of Dr. Branch. I had no idea she's coming off a vaccine. She's got some fatigue, got some general soreness. Dr. Mendoza, can you just briefly let our viewers know what you've seen and some of the heroics you've seen from the medical community in the last 9 months?
Goodness, I mean, we don't have enough time to talk about the extent of heroism that we've seen in our community since March. But the reality is that I am so proud and so grateful to be a part of this community and to do my part to get us through this. And that Dr. Branch was able to convince somebody who was on the fence is a great example of the fortitude of our community, that honestly, most people in our community just want to do the right thing. And given the tools, given adequate information, and given the space and comfort to ask questions, we'll ask those questions and arrive at a very reasonable conclusion. And it's this very principle that makes me so optimistic that for all of the skepticism and confusion that there might be right now, that we will get through this, and that we do have time. And although 6 months seems like a short period of time, I think these conversations are going to happen in every corner of our community. And I am optimistic that we will come through this, and that this time next year we'll be having holiday parties and going back to the symphony at the RPO.
There you go. Dr. Mendoza, given that you had that vaccine yesterday, here's a question from a viewer that comes up quite often, which is, it's even a question I had. When you get the vaccine, if you have side effects, can you take Tylenol or something else to help with those side effects, or should you let your body deal with it? Dr. Mendoza?
I think it's very reasonable to use some symptomatic treatments like Tylenol or ibuprofen. A warm compress on your arm is good. Stretching is good. But if you feel like something is unusual, I think it's important to consult with your healthcare provider, because even though these adverse events are very rare, we still want people to do the right thing and not feel like they're all alone and don't have somewhere to turn to. So, people know their body better than anybody else. If something's unusual, we want you to ask for help.
Okay, does that work for you, Dr. Branch? You just had the vaccine too. Any Tylenol or anything else?
I took ibuprofen last night, and it helped a lot.
There you go. Okay, that was great stuff. I think a lot of people had that question. Here's one I'm going to direct to Dr. Bennett. William says, and Dr. Bennett, I'm just going to preface this by saying I'm sure the answer is we don't fully know yet, or it will sort of come in different stages here. It's very complex, but William is saying, how does the committee or whoever identify the people and their health issues in order to place them in the different tiers? And then how do they determine whether a person is more at risk than another with comorbidities? Dr. Bennett.
That's a really good question. In the case of healthcare workers, we've been able to identify who's at most risk because of where they work and what the nature of their interaction with patients is. When we get, and the rest of Tier 1 is long-term care patients and staff, so those people are pretty easy to identify. When we get to Tier 2 and we're talking about essential workers, again, we know who the EMS workers are. We know who the fire department workers are. We know who the police are. Those first responders are fairly easy to identify. But when we get to essential workers, other essential workers, it will become complicated. And in all likelihood, I think people will have to self-identify. So we will have clinics, or people will go to their doctors, or people will go to pharmacies, and we'll ask them to self-identify their risk. Obviously, we can't identify every single grocery store worker in this community and make sure they get their vaccine, but we will certainly try to use every possible way of getting to those workers, be it through stores or through whatever their business happens to be.
You're going to get tired of talking to people in the media like us, Dr. Bennett.
I know. We're going to have to do a lot of it.
Oh, my gosh, all of you. It's a lot, but we'll be here communicating. Susie has a question about transmission. Let me ask this question, and I'll attach what has also been sort of a common addendum to it. She says, what do we know about antibodies in the vaccine? If someone had COVID-19, say back in March, and still has antibodies, can they carry and transmit this virus? And coupled with that, Susie's question, I will ask whoever, I guess I'll kick this to Dr. Topham. You want to take this, Dave? Is that all right with you?
Sure.
I feel like you all can do this. But let me, Dr. Topham, let me also say a common question people have is, do we yet know if getting vaccinated means not only are you not likely to get sick, but you also then can't transmit? Do we have enough data on that yet, Dr. Topham?
I would say we do not have enough data on that. We do know that people who have been infected, there's a very small number of them, but there have been cases of reinfection. So the immunity may not be sterilizing, at least the immunity conferred by infection. The immunity conferred by vaccination, at least in terms of the amount of antibodies that are made, has often been higher than we see in convalescent subjects. So it's possible the vaccine is actually better at protecting you. But again, there are several vaccines that we have on the market that are approved that protect you from getting illness, but do not protect you necessarily from getting infected or continuing to shed the pathogen. Is
there a sense, though, that we should expect that if you get vaccinated, that you will not likely be able to transmit, or because I actually don't know what's common with other illnesses. I sort of assume that the answer is yes, that if you get vaccinated, you probably won't be able to also carry and transmit, but I don't know that, Dr. Topham.
I think the chances are that with the right level of immunity, the antibodies will prevent you from getting infected at all. And so, of course, you won't transmit if you're not infected. And if you are infected, it'll be at a very low level. And again, your chances of transmitting when the virus levels are very low, again, are reduced. So I think there's every reason to believe, and I think we'll know fairly quickly whether or not people who have been vaccinated and get exposed are able to transmit the virus. We'll be collecting that data, I'm sure, and watching very closely.
Okay, but we need that data first, of course. Dr. Walsh, does that make sense to you? Does that square with your ideas on this?
Yeah, it does. I mean, the vaccine trials were not developed at this early stage to assess the transmissibility of those who became infected following infection. Although there is some data that does suggest, as Dr. Topham just pointed out, that vaccinated individuals are very likely to be less likely to spread the virus to others.
All right, going down the list of questions, Keith says, my question is regarding snowbirds. We are 64 and 65 years old and hope to winter in Florida as usual. We will return home in April. I'm not sure what to expect with respect to vaccine availability for us in Florida. I understand the distribution strategy is at the state and regional levels. The optimist in me wants to believe we might get the vaccine before our return in April. Does the second dose need to be administered in the same state and location? Dr. Bennett, have we covered that yet?
No. I don't know the answer to that question. We do know that we would like people to get the same type of vaccine for their second dose. So that would be important. If the states were giving different types of vaccine, that could be a problem. But in terms of being able to get your second dose in New York and your first dose in Florida, I really don't know the answer. I don't see why there would be a problem, but I just don't know the answer.
Okay, I'm going to try to squeeze in just a few more, and then we're done here. Tim writes to say, many people seem to think that they can bring a grandparent home from the nursing home on weekends once that grandparent is vaccinated. Perhaps that will be true, but please make sure people understand that the vaccine might not work on 1 in 20, and therefore, until enough people are vaccinated, precautions still need to be taken in case your grandparent is one of the 1 in 20. I'm going to ask Dr. Branch about this because on the main program, Dr. Branch, you talked about the fact that not only is the vaccine designed to make sure you don't get the illness, but if you do get the illness, maybe it's less intense. Given Tim's point here, efficacy is not 100%. How do you address the idea that people think, well, I'll just bring grandparents home on the weekend?
Yeah, I think this goes back to the issue of can you become infected if you're vaccinated and can you transmit the virus? So as Dr. Walsh mentioned, none of the U.S. studies have really been designed to answer that question. We do have some data from the UK AstraZeneca study that was conducted in Brazil, where they were swabbing people's noses every single week, regardless of whether or not they had symptoms, and they were able to detect asymptomatic infection in people who had been vaccinated. And so I think that it's certainly possible that even if you're vaccinated and you don't become ill, that you could develop an asymptomatic or mild infection. It may be a very small percentage of people, but on the other hand, you don't want your 90-something-year-old grandmother who you brought home to become that asymptomatic carrier that takes it back to their healthcare facility and infects people there.
Yeah, the hard part here, Dr. Mendoza, is this is in line with the idea that we have to be optimistic about how life is going to slowly start to move back to what we consider normal, but we don't want to be overconfident. We got to still be careful. And when we think about the most vulnerable, a vaccine doesn't immediately mean everything is off the table, I guess, with protection. Fair enough, Dr. Mendoza?
Yeah, this is going to be a very atypical time. You know, it's delayed gratification in the truest sense of the word. You know, we will never have had to go through something like this. And so it will be a test of our mettle. We will have to figure out how to take these precautions, get our vaccines, and then some point in the summertime, we can perhaps let our guard down and celebrate. But I think we have to consider this as still, a marathon in many ways.
I'm going to close this discussion with just a few comments from all of you on the subject of children. We get a lot of questions on this. We touched on this in the main program, but let me do this. I'm going to ask you just maybe a question apiece here, because it comes from a lot of the parents who are wondering. Dr. Bennett, when we see kids are part of Phase 5, they're part of Phase 5, I guess, if we get the green light for 7, 8, 9-year-olds. So as much as they're part of Phase 5, I sort of think of them as Phase 6. How do you think of it?
Yeah, I agree with you. We really don't have a vaccine that's licensed in children yet, and it will probably be some time before we do. As Dr. Walsh described, it's going to take a while before these studies are done in children. So I would think of it as Phase 6, too.
Okay, Dr. Walsh, when it comes to kids, is there any reason to think that it's going to be difficult to achieve a COVID vaccine for kids that will be safe?
No, I don't believe it will. I think that with the multitude, by the time we are studying children, there'll be several vaccine candidates that could be used in children. And I think, this is one of the advantages of having multiple possible types of vaccines.
Okay. Dr. Branch, can you weigh in on that as well?
Yeah, the NIH has already started working on designing these trials for kids and choosing the vaccines that are going to study them. I think that some of these trials will start maybe at the end of January or beginning of February. It will, as Dr. Walsh talked about, be an age de-escalation study. Well, you'll start in 12 to 16 years old, and then 8 to 12, and then maybe 5 to 8, and then to some of the younger ages. So I think that as these different age groups are trialed, then the possibility of vaccinating those age groups opens up. But in terms of the youngest group of children, that might still be a ways away.
And Dr. Topham, we get questions from listeners and viewers in the community who say, hey, can you ethically bring kids into trials? Can you bring pregnant women into trials? How do you bring people into trials ethically, based on certain backgrounds?
Yeah, we have rules governing how we bring children and people with other risk conditions into clinical trials. Again, extra precautions are taken. We have to get the assent of the child and the consent of the parents. They have to be informed of the possible side effects. But we've been doing this for a long time, and I think we know how to do it, and to do it ethically and safely.
Well, Dr. Mendoza, I said to Dr. Bennett earlier, she had the question that the audience, that the group was going to hate the most, but I lied. You get the one that you're going to hate the most, because it comes from parents who want to know, do we yet know if school next fall will still involve masking and distancing and remote learning and hybrids? I'm sure it's too far away. It's still 2020. But given the fact that kids are essentially Phase 6, vaccines for them will be later, assuming they come in 2021, should parents be thinking ahead, being prepared, or is that way too early for that?
I think it's way too early for that, but I think it's very reasonable for parents to prepare for it, to plan for it. I think it's a very decent likelihood that we'll still be using these precautions even into the fall next year. But I'm hopeful. I'm hopeful that we won't need to. I'm hopeful that if we can get the entire community vaccinated appropriately, and we have enough knowledge about the transmission among K through 12 age students, there's a possibility that we may not need to. But I think the safer approach would be to plan on it, and then perhaps we might be pleasantly surprised. But I think time will tell.
I will wrap now tonight and say that for those watching and listening, we are blessed not only with tremendous talent and people with just great achievement and skills in the community, but you're also phenomenal communicators. It matters to us. It matters to the community. I apologize in advance for all future phone calls to you, asking you to come back on Connections or come back to WXXI, but I know the community needs to hear it. So thank you to all of you. Thank you so much for this. And for those watching, if you missed tonight's forum or want to watch it again or share it with those who need the information, it will be posted at WXXInews.org and on the WXXI News YouTube channel. Doctors, all of you, I'm waving goodbye and good night, and I want to say from all of the audience, thanks for what you do.
Thanks very much.
Thank you.
Good night, everyone.